Greetings, pharmacology students. Welcome to week 4. We're going to look at the drugs that affect the autonomic nervous system. Remember that that's your involuntary nervous system, and then we're also going to start looking at drugs that affect the respiratory system. Last week, week 2, we looked at central nervous system and peripheral nervous system medications that affect those two. So in chapter 29, that is an introduction to the autonomic nervous system. My belief is that if you've taken physiology, you might, well, it depends on how long ago you took it, I guess. You might have a pretty good grasp on this whole autonomic nervous system, how it works, the sympathetic and the parasympathetic system. But if you don't, do take a look at chapter 29. If you think there's some, at least look at some of the diagrams that tell you about which organs are innervated by which system, etc. Chapter 30 starts on the adrenergic agonists medication. So here I'm just going to emphasize the word agonists we think of as pro or stimulating versus the adrenergic antagonists, which you'll see in some texts. In this text, it uses the word antagonist. In other texts, it'll say anti-adrenergic agonist, which is basically the same thing. So think of the adrenergic agonists as medications that are going to stimulate the alpha and the beta of the autonomic nervous system. Look at table 30.1. for some medications that fall into that category, ones that you'll recall, especially paramedics, epinephrine. I don't know whether you use dopamine or not, but you've heard about dopamine, usually used in the ER or critical care. Dopamine is in that category, as well as norepinephrine. Also look at table 30.2 for alpha-specific agonists. The first category I mentioned were alpha and beta. There are alpha specific that only relate to the alpha side of the autonomic nervous system. And one of the medications there to look at is phenylephrine or neosynephrine. And I think that's the drug that you have to sign up for. And that's the drug that they use to make meth, or they used to. I don't know if that's still a thing. So in this chapter, chapter 30, look specifically at those 4 drugs that I said, dopamine, epinephrine, norepinephrine, and phenylephrine. And then also look at the box that tells you about the use of these drugs across the lifespan, and concentrate on the nursing considerations for patients that are on these medications. What are the important teaching points for patients that are receiving these, not only that you need to know as a nurse, but that you need to teach your patient about. Also, across all these chapters, I want you to be focusing on what are the desired effects of these medications, what are the adverse effects of these medications. Going on to chapter 31 is the adrenergic antagonists. So these are the blockers, the adrenergic blockers. And of course, in this category, we come across the beta blockers that you'll know because they end in OL. Generally, a beta blocker ends in OL, like atenolol, labetalol, and propranolol, which is the generic term for Inderal. Another one in this category is carvedilol, which we know as Coreg. Then we think of blood pressure meds and heart meds and those kinds of beta blocker meds. But there's also drugs in this category that affect other organs in the body aside from the heart, or that their specific target area is other than the cardiovascular system. One of those medications is tamsulosin, which is also known as Flomax. So you'll frequently see a drug like this drug or a drug like it in the same category prescribed for patients who have benign prostatic hypertrophy, because this will help to facilitate the flow of urine. Again, I want you to look at the desired effects of these drugs and the adverse effects of these drugs. And again, this is like repeating with every chapter. Look at the nursing considerations, the important teaching points for patients that are receiving this category of adrenergic blocking agents. Okay, chapter 32 are the cholinergic agents or the cholinergic agonists. So these are the pro-medications that are going to stimulate the parasympathetic nervous system. The adrenergic, think of the sympathetic nervous system. The cholinergic, think of the parasympathetic nervous system. Acetylcholine is the neurotransmitter that is most affected by the cholinergic agents. In this case, we're talking about drugs that would stimulate the release of acetylcholine or the effectiveness of the acetylcholine. So specific drugs in this category would be bethanechol, which is also uracil. This stimulates the urinary tract. There's a couple medications that actually have a positive effect on Alzheimer's. That would be donepezil, which we know as Aricept, and also Namenda is in this category as well. Once again, what are the desired effects? What are the adverse effects of medications in this category? What are the nursing considerations and the important teaching points for patients on a cholinergic agonists? Then moving on to chapter 33, which is the anticholinergic agents. So this time they put the anti in front of the nervous system type, the anticholinergic agents. And this would be, paramedics, your favorite, possibly atropine, which we know as a parasympathetic blocker. So think of the anticholinergic agents as opposing the acetylcholine at the receptor site. Remember that it's a neurotransmitter, and the parasympathetic blocking agents are going to oppose that transmitter at the receptor sites. So I want you to, again, what are the desired effects? What are the adverse effects? Look at these medications across the lifespan with possibly considerations for the elderly, and then the nursing implications. Really, atropine is probably the best example in this category. There's a drug Ditroban, another one Detrol. Both of those are used to treat the urinary tract. Also scopolamine, we know this scopolamine patch is used sometimes for vertigo or motion sickness. Also belladonna is in this category. They use belladonna along with opium as a suppository, sometimes for post-op patients who have undergone prostate surgery. It relieves pain, it relieves spasm in that area. Back in the day, this is the way I had like on real life clinical experience in separating this category of drugs. I worked in the cath lab, and one of the things we had to do is pull the arterial sheath from the femoral artery that was used during left heart cath, it still is today, to inject dye so that they can see the arteries under fluoroscopy. So they would also inject heparinized solution through that to keep it from clotting, obviously because it was in an artery versus a vein. But one of the things we had to do in the recovery area was to pull that sheath. And when I was new in that department, that was quite a scary thing, because if you didn't apply sufficient pressure to the puncture, and you didn't have the right amount of pressure and you weren't in the exact right location, you would end up with blood on the ceiling, because it's arterial, blood on yourself, and you'd be able to witness a huge hematoma forming right before your eyes. Well, I did learn to exert sufficient pressure, which is quite a lot of pressure. You cannot be distracted. We had to maintain pressure for a minimum of 10 minutes. And sometimes your hand or wrist or arm would actually start to shake from holding it in that same position. But what we were actually doing in exerting pressure on the artery, just like you say when you're bleeding, the first thing to do is to apply pressure. We were trying to stop the bleeding from that puncture. But we would inadvertently I say myself and the other nurses, occasionally, inadvertently, we'd also be compressing the vagus nerve, the vagal nerve. The vagal nerve is an important component of the parasympathetic system. So what we were doing while we were busy trying to stop arterial bleeding is we were actually creating a stimulation for the vagus nerve. We were stimulating the parasympathetic side. You know, there's always going to be a balance between sympathetic and parasympathetic. Well, if you stimulate the parasympathetic, what happens to your heart rate? Goes down. So I always had in my mind a way to remember the parasympathetic stimulation as a couple things. One is if you've ever passed out, if you've ever fainted, you'll be overcome with all these symptoms of parasympathetic stimulation. You might start to salivate, you might get ringing in your ears, you might start to feel dizzy. All of these are symptoms of parasympathetic stimulation. Same thing if you've ever gotten sick and you need to vomit. That prelude to vomiting sometimes are those same symptoms. You might start to salivate, you get ringing in your ears, you feel dizzy or woozy. All that is parasympathetic stimulation. And if you were to take your heart rate, you'd probably be in the bradycardic zone. So occasionally we'll have these patients fully monitored, so they'd start with a blood pressure and a heart rate, let's say heart rate in the 80s. But as time goes on, we're watching their heart rate and we're seeing their heart rate start to fall. We knew we were stimulating that vagus nerve. And then sometimes the patients would tell us themselves, we're watching their vital signs. They're getting blood pressure every 5 minutes, and of course we can see their heart rate. But sometimes they would start to verbalize these same symptoms. And they'd say, I'm not feeling very well. I don't feel very well. I'm getting ringing in my ears. And the other thing we started to do is we just bring some atropine with us to the bedside. I never had to give a patient atropine because if you realize what's happening and it's safe to let up a little pressure on that vagal nerve, then that stimulation goes away and the sympathetic side comes back and starts to regulate everything so that you're once again in balance. But as I say, we would bring atropine to the bedside because why do you give atropine? Why do you give a patient atropine during a code? Why do you give a patient atropine in the field? To bring their heart rate up, right? Anyway, I don't know if that's going to help you. There's lots of places in your body that are responsible for parasympathetic stimulation, but the one I'm always going to remember is the vagus nerve. So let's move on to chapter 53, which is the introduction to the respiratory system. Just as I said on the introduction to the autonomic nervous system, if you feel you got the respiratory system down, if you see lots of respiratory patients, you see patients who have, I would say, with the concentration on lower respiratory issues, with the exception of maybe asthma as an airway problem. This may be a quick review, or maybe you don't feel it's necessary. But chapter 53, it's called Introduction to Respiratory System, and it does differentiate your upper and your lower respiratory system, with the main upper respiratory issue being a common cold, and then a couple of serious lower respiratory tract clinical presentations. I want you to look at atelectasis, pneumonia, asthma, and COPD with a focus on those four, and discuss the signs and symptoms or the clinical presentation of patients with those conditions. And then the next two chapters, your last two chapters here for this week, chapter 54 is drugs that act on the upper respiratory tract. Chapter 55 is the lower respiratory tract. So let's look at 54 first. See at the beginning of the chapter, it's called drug list. See the classes of medications that are given for patients. Also look at across the lifespan, the box that's called across the lifespan, with the emphasis on the elderly. You can overlook the pediatric patient as far as I'm concerned. In this chapter in particular, I want you to look at antitussives, the category of antitussives, and also expectorants. So antitussive is going to stop the coughing or suppress the coughing. An expectorant is going to liquefy secretions and actually promote coughing or promote effective coughing. So it kind of makes sense that you're not going to give them both at once, but sometimes it's up to the nurse. Sometimes they'll both be ordered for the patient as a PRN medication, and then it's kind of up to the nurse to determine with the patient how the patient's feeling at the time, which of those medications it's appropriate to give. And I want to say kind of a rule is the patient needs to sleep, right? So it might be appropriate for you to administer those antitussives at nighttime. And then the expectorant, the guaifenesin, is a good example of an expectorant during the day. So look at the nursing considerations and the teaching points for those upper respiratory. And then the lower respiratory tract medications in chapter 55. Again, look at the drug list. And here we're going to focus on the bronchodilators and also the category that goes with these disorders of the lower, like we said in the two previous chapters, which are atelectasis, pneumonia, asthma, and COPD. These categories of medications, the bronchodilators at least, are going to be in the beta agonist classification, not the beta antagonists, the beta agonists. And they're going to dilate airways by stimulating the beta 2 receptors in the lungs. This chapter doesn't really I don't think they differentiate what I'd like you to walk away with, which is recognition of what are the long-term medications for these disorders. Let's just focus on asthma, for instance, versus the rescue medications or the short-term medications. And many asthma patients present to EMS or to the ER, well, because they've got an exacerbation. We think of exacerbation in asthma typically being caused by cold or exercise. Sometimes a food or a food group can exacerbate asthma. But very often we see that patients are not taking their asthma medications as prescribed. In other words, they're not taking their maintenance medications. So those would be the long-acting medications versus the short-acting medications, which we look at as rescue medications. So when we're talking about albuterol inhaled, we think of that as a rescue medication versus Atrovent or Spiriva. We think of those as long-term medications. So when you've got a patient who's just been prescribed or just been administered these medications, what kind of clinical changes do you expect to see? Of course, tachycardia. You can have a patient who develops chest pain. They may complain of a headache or a tremor, and they may become hyper or in some cases hypotensive. Look at these medications in chapter 55 by class. Then also, what are the nursing considerations? Again, the desired versus the adverse effects, which I've just mentioned some of the adverse effects, and the nursing considerations, meaning the important teaching points. One is, I just alluded to, the proper use of these medications on a daily basis. Watch for your week 4 quiz to be assigned in the Prep U portion of your online course. By Monday or Tuesday, I should have that up. And then I'm also going to post a quick little overview of how to use one more resource that you have. Specifically, it's a drug lookup that you can do when I mention some of these drugs. If there's not a prototype in your chapter, where is the best resource for you to go to look at these drugs? And you can do it right within your course point course. So that'll just be a quick little video for you to watch. And I'll post that in week 3. Okay, have a good week.